Keratoconus is wacky because it's actually an autosomal dominant inheritance path, which means it should be very, very strong with its representation, but it has incomplete penetrance, which means it doesn't show up in the same way that an autosomal dominant disease would. And that again comes back to its multifactorial approach. So you've got to have all of the special herbs and spices in your environment and in your history, as well as that genetic profile to put you at risk of keratoconus. So some of the risk factors for developing it are things like a family history. So if we've got a family history, that's your inheritance link, isn't it? We've got a history of atopy or allergy. So if you've got a reactionary system or a reactionary eye, then actually you're going to be more at risk because you're going to be more likely to be eye rubbing and so on and so forth. People with connective tissue disorders, because the cornea is a connective tissue structure. So anything that is a disorder that might affect your connective tissue could have an impact on the cornea as well. Eye rubbing that we've talked about extensively already so far in this interview. Down syndrome's another link. So if we're talking about Down syndrome kids, it's a very high penetration of keratoconus with their eyes as well. And slightly higher in Asian and Arabian ethnicities as well. So if we start having patients that are from Iran or Iraq or what have you, then the incidence is a little higher, same as people from, Vietnam or Korea or Japan or China as well. And I've seen new onset confirmed diagnoses of keratoconus in people pre-10. So we're talking under the age of 10. I've seen advanced keratoconus at age 13, where it's suffered severe vision loss in one eye. And these are picked up for the first time at these ages when I'm seeing them. But the common age for things is the highest incidences, but is in your 20s and 30s. So it's a younger age type thing. So although we see it in exceptions in children and teenagers, the major link is probably 20s or 30 somethings. And I guess if you think about when do we try and recommend people have their eyes tested, we recommend there should be an eye test, before the start of school, so before the age of 5, which is not going to find keratoconus. We also recommend regular checkups through school, which may or may not find keratoconus. When we should be looking for this the most is when people in their 20s and 30s, which is often the stage where if people don't have a vision problem, they don't get regular checkups. They stop and wait until they get to their 40s and they're getting presbyopic and losing the close vision before they come back to the optometrist. So I've had a whole heap of new patients coming into the practice just recently, all in their, my age, so 40 to 50, all coming in, haven't had a checkup since school. So in one way that's pretty good, because if they haven't had a checkup since school, then they haven't had a vision distortion or a problem with their sight that's caused them distress. But other people have said, yeah, they've had vision distortions and problems with their vision, but they've just sort of lived life and they haven't still gone and got it looked at. So again, it comes back to regular checkups are still sensible. And if you've got even an inkling that something's not quite right, then you should be getting checked.
So if you're from one of those high risk demographic groups that you talked about, or ethnicities, or the backgrounds that you talked about, if you've got let's say a family history of keratoconus, when would be a good age to start getting regular keratoconus checks, if that's the case?
From the end of your teenage years and onwards, I would think is probably the most pertinent. Even if the diagnosis is in your 20s, there's going to be signs that mapping and other investigations in your late teens. And I think because it's a multifactorial disease, the more of those risk factors that you've got, the more reason for you to come and have an earlier checkup.
Right.
So if you're Asian and there's and you've got Down syndrome, and you've got a connective tissue disorder, and you've got allergies of your eyes, you should be getting your eyes examined and double checking that you don't have keratoconus for sure.
Or if you're Tasmanian.
Or Tasmanian as well. And if you're Tasmanian, you've got a bit of allergy and all those things. So all these things are worth getting a checkup. And occasionally I'll get someone that's cognizant enough and they've read something about this or they've heard something about this, and they come and ask for a keratoconus review.
Yeah.
And it's, why is that? Because it's not a common thing that people ask for. And sometimes it's because, my dad's got keratoconus, I've got some allergies, and that's the reason, I'm doing it to keep my father happy, but or my mother happy or something like that. But so it's anything that's a variety of risks, then it's a higher reason for you to get, a checkup, even if you think things are fine. It's nice to have a screening.
Interesting. Okay.
And because it's considered a progressive disorder, sometimes having a regular screening is great because it gives us a baseline.
Of course, yeah.
Even if the thing is normal, we've got a baseline, which means in 2025, when we've done the scan, it wasn't there. And you come back in and there's a little bit of a change in 2 years' time. It has appeared within those 2 years, so we know it's starting now.
And of course, it's
never,
always
never too early to have a baseline. Yeah,
never too early. And of course, that sort of presupposes that your optometrist has got the right sort of diagnostic equipment to take a good baseline, right?
Or the right assessment that you go there, and if they're a bit suspicious, that they'll refer on, because most of the ophthalmology clinics, and certainly myself as well, will take referrals of patients just to do scans, just to look for keratoconus. And then we do a scan, give the patient a copy of the scan, and we send them back to their optometrist. And the same thing happens at ophthalmology. So, and I do the same thing if I'm looking for something that I'm a bit suspicious of that's in the posterior cornea, because I can't assess that in great detail. I'll refer to the local ophthalmology practices just for a pentacam scan, and they'll accept that as just a scan, and they don't do a whole consult. There's not a massive fee. There's just a fee for the scan. And then the results come back to me. And if I do that liaising with, say, a corneal specialist, then they'll have run their eye over it as well and give me a heads up whether they think there's something suspicious in it or not.
Interesting. Okay.
So it means a better cost triage system.